This is a good case of a patient who had to have their intraocular lens removed and replaced with a different lens.
So different tools that I use here. This is a little spatula at the tip with viscoelastic coming out. So that spatula allows me to go underneath the edge of the rexus to inject viscoelastic that then opens up the bag that the lens rests in. And that then allows me to remove or rotate out the two haptics. So it leads little feet into the anterior chamber and then get the lens out of the eye.
And when you use the term rexus, that's that opening of the front of the capsule. When this first surgery happened, the cataract surgery, there was just an opening made, a front window, we could call it. Cataract was removed and a lens was put in its place. So now we're seeing the reverse of that, where that's needed to be pulled back out of the capsule.
Correct. And then here, as you can see, some manipulation, lots of manipulation actually to get the lens into the correct position. And the lens is foldable, as are those little feet and haptics. This little window in this specific lens is a nice entry point to get the lens and haptic out of the bag. And then I kind of use two little instruments at the same time to get it in the correct position. This is a little grasper to get one of the haptics out of the wound. And here I'll be using a twist and out technique, meaning I will roll the whole intraocular lens, the optic of the intraocular lens, around a forceps while protecting the endothelium and thus decreasing its size so that it fits through that small opening created in the beginning.
Yeah, the corneal endothelium is the part I get the most nervous about just watching anything like this, because if that gets interrupted or disrupted at all, you could have a situation where with no endothelium functioning, the cornea is going to swell up. So that seems like that's going to be a top priority here, getting this lens out.
And so more viscoelastic is placed behind and in front. So if things move, I have something that maintains space. So this again goes across, viscoelastic all the way. And then I also hold this in place as I twist now the forceps in my hand and roll the optic around the forceps. Make it smaller and smaller so that it fits through that small opening in the beginning. You can see how it all curls up, is now twisted around that forceps. And here it comes out, fold it up one more time, and it's out.
Just very soft tissue. It really just folds up nicely.
Yes.
Now this is the new lens coming in place, and there's a lot of reasons why a patient might need an old lens removed. Perhaps it was the wrong power. They have other complications from that lens.
Or they have other symptoms. They can tolerate the lens design. Multifocal lenses I tend to have to remove sometimes, or like you said, if the power is wrong or the axis is wrong in a toric lens, again, multiple reasons why a lens might not work or opacifies, or has other issues.
Is there anything about the first surgery with the capsule and now putting in the new lens, is there something that changes with the capsule that might make it hard to get the new lens in? Or once you get the old lens out, you're pretty much ready to sneak the new one right back in?
That's a very nice way of saying that, correct. So the challenge is getting the old lens out. If you get the old lens out, you're able to open the bag wide enough. Thus, it's then easy to get the new lens in, but getting the old lens out is the hard part.
So this is the part where we can feel a little more relaxed, and it looks like just a cleaning of the anterior chamber now.
Yes, and the viscoelastics to decrease the chance of a pressure spike. That other instrument is to keep that lens in place so that it has less likelihood to move. Sometimes I also move the iris out of the way to make sure that the lens is in the correct space.
Is visco, just since you mentioned it, is visco the main culprit for the increase in pressure? Is it just blocking the trabecular meshwork, blocking the outflow of the aqueous fluid then?
Yes, that's the theory, because it's a higher molecular weight, so it can't pass the trabecular meshwork as easily as aqueous can.